Hi, everyone. Welcome. As we're letting everyone into the chat room and everyone's logging in, I just want to ask everyone to just make sure that your mics are on mute. If you have any questions for Dr. Altschul or for the team, if you can please put it through the chat, that would be great. Some questions we might field in during the talk, but we generally reserve any questions towards the end if we have time. We do try to keep this webinar at 60 minutes. Anytime after that, we have not felt that it's been beneficial. So we try to cap it at 60 minutes. But if there are any pending questions, I will email them to Dr. Schul and reach back to you individually for any pressing questions. But welcome and thank you all for logging in today. We know there are people from all around the world, different time zones, so we're very grateful for your attendance for this webinar. Um, my name is Edith. I work with IIH Hub. I help as a webinar coordinator and writing some articles. And I am delighted today to welcome back Dr. Dorothea Altschul. We had the pleasure of having her 2 years ago on the topic of pulsatile tinnitus. And if you would like to watch that video, you can find it on our YouTube channel, IIH Hub. I will have an article posted with all of this information as well. Dr. Dorothea Altschul is a renowned board certified in neurology and vascular neurology, as well as CAS certified in neuroendovascular surgery, and has been practicing for over 16 years. She is the director of neuroendovascular surgery at Valley Hospital in Paramus, New Jersey. She has innumerable accolades, including being a senior member of various professional societies, including the Society of Neurointerventional Surgery, the Society of Vascular and Interventional Neurology, and the American Academy of Neurology. She is also a member of the editorial board of the Journal of Neurointerventional Surgery, the most premier scientific journal in her field. Welcome. I'd also like to introduce our moderator today, Dr. Brian Snelling. He is a neurosurgeon and director of cerebrovascular and endovascular neurosurgery and is the director of the stroke program at the Marcus Neuroscience Institute, part of Baptist Health. He has been practicing for over 7 years. He is proficient in the treatment of management of IH and has been a speaker at our prior webinars. I'd like to welcome you both today. Thank you for your attendance. Thank you, everyone. I'm going to put myself on mute and come off video and hand the mic over to Dr. Altschul to discuss venous manometry.
Thank you so much, Edith, and thank you to IIH Hub to give me that opportunity to talk about venous manometry, which is essentially just saying that we measure the pressure into the brain's veins. Some of you may have wondered how that is done or what this is for. And so I hope to give you a little bit of an overview today. So why measure pressure, brain pressure at all? And it really came from the notion that the brain lives in a closed box called the skull. And much what we understand about pressure in the brain actually comes from trauma and from acute injury to the brain, such as having a bleeding in the brain or a tumor growing in the brain. When that happens, the brain pressure rises in the brain, which then can cause, a multitude of symptoms. If that happens acutely, it could even be life-threatening. But if it happens more slowly, it can cause headaches, vision changes, dizziness, imbalance, and tinnitus or pulsatile tinnitus. And the pressure under normal conditions that you see on the left side here is remarkably well controlled. And there are several compartments inside the skull that need to be kept in balance. And so the roots to understanding the pressure in the brain go back over 200 years ago to two Scottish physicians. Actually, Monroe lived a few years before Kelly, and he really described for the first time that inside the brain, inside the skull, we have the brain, the blood, and the cerebrospinal fluid, and one increases, the other one must decrease to keep the pressure steady. So you can see here on one axis we have the intracranial volume, and on the other one we have the pressure. And so if let's see, let's think if we have something growing inside the skull like a tumor, the pressure will start to rise, and it will displace the blood volume or the cerebrospinal fluid. And eventually, uh, when tumor continues to grow, the pressure will start to rise. And this notion led to the term pseudotumor cerebri for idiopathic intracranial hypertension, because a lot of these symptoms of high pressures can present like someone would have who has a tumor growing inside the skull. Now, however, 200 years is a long time, and we since have evolved our understanding of this sort of very important doctrine that Monroe and Kelly has left us with. And so to the next sort of step was the Monroe-Kelly 2.0 doctrine, and that said that the intracranial pressures are actually also dependent on extracranial pressures. And so if you have intrathoracic in your chest or intra-abdominal pressures, they can actually influence the intracranial pressures through venous and cerebrospinal pathways. So it's not that the brain is completely isolated, but that there is a dynamic interplay between pressures. And so, for example, venous occlusion or impaired outflow can elevate the pressure in the brain independently of any changes in any arterial or CSF dynamics. And then later on, or the most recent understanding is that there are also compartments in the brain that probably play a role in the intracranial dynamics, such as the interstitial space. So the interstitial space is sort of a fluid-filled space between brain cells, and it's only 3.5% of the entire volume inside the brain. But it seems that it has a role in the cerebral autoregulation and in the lymphatic system. And a lot of that was found from like traumatic or spontaneous subarachnoid hemorrhage, that there seemed to be a secondary brain edema development due to lymphatic obstruction. So this is certainly an area that we are is still under research to understand this better. But it is important to emphasize that this is actually a dynamic interplay by various structures to keep the intracranial pressure steady. Now, what were the pioneers of pressure measurements? So going back to 1891, Heinrich Quincke, which is this gentleman on the left, invented the lumbar puncture. He was a German physician, and he was the first one who was able to measure pressure, to access the cerebrospinal space through putting a needle into the lumbar area. And this test was later refined by Queckenstedt, who actually, interestingly enough, developed a test where he put a needle inside the lumbar area and measured the pressure in the cerebrospinal fluid space, and while obstructing the internal jugular veins. So he pushed in the internal jugular veins, and if the pressure would go up, that meant that the system meaning the pressures inside the brain were in balance with the spinal pressures, and that meant that there was no obstruction anywhere along the pathway. And this is how they could tell if there was any blockages along the way back in the day. And the picture on the right is a photo from like around 1913, where lumbar puncture, the first sort of lumbar puncture tests were done the way we know it today. And these are physicians that it's not entirely clear where this picture comes from, but I have to say that the first lumbar punctures were actually quite dangerous, and the first 5 patients actually happened to die when they started doing lumbar punctures. At that point, lumbar puncture was only done for therapeutic measures and not for diagnosing anything. It's only done to relieve pressures. Now, lumbar puncture, however, is an indirect measure of the brain pressures, right? Because the needle is put inside the spine and not inside the brain. So it works well if the system is communicating and all the compartments are in communication with each other, but it's still an indirect measure. And it was only until 1950s to 1980s that we developed the direct brain pressure measurements, and the extraventricular drainage tube, as we know it today, has been developed. That was, mostly done for trauma patients who were very sick and had potential bleeding and other things in their brains. So nowadays, the extraventricular drain, which is the V here marked, is when you put a tube directly into the ventricle and you measure the pressures directly into the ventricle, is sort of considered the gold standard of brain pressure measurements. But we also have ICP monitors, which is marked here as P, where there is a small sensor put directly into the brain parenchyma. Somewhere along the way, there were epidural brain pressure sensors that actually are considered not reliable and not used very widely. And then there are also wireless sensors that can be placed. Well, I mean, just looking at this picture, this all seems very invasive. And I actually hope no one is passing out when I talk about that. It doesn't seem to be very practical and very safe for patients who are not in a very traumatic and in a situation where they have acute pressure increases. And therefore, for diseases like IIH, that seems to be quite impractical, but it's important to realize that the extraventricular drain is still considered sort of the gold standard of pressure measurement. Now, therefore, what we have as the best pressure measurement in our guidelines that is sort of more safer and more widely used is the lumbar puncture. And you're probably all familiar with that. You're supposed to lie on your side when measuring the pressure through a lumbar puncture. Nowadays, it's an important tool because not only is it diagnostic, so you can study the composition of the cerebrospinal fluid, but you can also measure the pressure and relieve the pressure. So if there's a question what symptoms are caused by the increased pressure in the brain, relieving it may answer the question. However, the spinal fluid buildup is quite fast, and the moment you relieve it within 24 hours or so, usually the pressure is sort of built up again. In addition, it's important to use a very small needle because in people who have high pressures, the needle creates, a puncture site into the dura, and those can lead to leaks. The reported rate is around 10 to 15%, but it may be higher in people with IIH. A lot of people have a hard time with the lumbar puncture. And so there's an alternative option, a lumbar puncture on the fluoroscopy, which is done on the X-ray, where you can, particularly in people who have a difficult anatomy or had, back surgery, you can focus more definite on into sort of on the space where the needle should go in. And often this is, a lot of patients prefer that as opposed to getting poked, so to speak. So these two measures exist. And in 1996, the first report came out linking that back then the disease was called Pseudotumor Cerebri, and now referred to as IIH, that in that disease, the venous pressures are elevated. And this was the very first study that showed 10 patients that had actually, some of them had ventricular and ICP monitors, and they also had a venography. And there it was confirmed that the pressures in the vein appeared to be elevated in those patients. And interestingly enough, not all of them had a stenosis in the venous system. So after this was published, and sort of there was a little bit of a shift also focusing on the veins in that disease. And so the logical next step, and I was bored from cardiology who had used venous manometry, is to go inside the veins and measure the pressures. And that would also help detect any sort of blockages, and is usually done during the venogram procedure. Around that same time, also cerebroangiography took off, and there were more centers performing angiography. And since the tools and the resources used are very similar, it also became something that could be explored for diseases such as IIH. Now, it appears that the brain veins matter in this disease and in general, meaning that if there is a blockage of outflow from the brain, that by narrowed veins or other reasons, that leads to a buildup in the vein more upstream inside the brain, a little bit like a kinked hose. And this then affects the CSF absorption. And looking at the veins, there are various different anatomies, but some of the veins carry more weight, so to speak. They carry more blood, and it's usually the transverse sinus system. We have a major vein going over the convexity, the suprasagittal sinus, and it divides into a right and left transverse sinus. And that vein was found to be often narrowed. You can see in the middle picture here, the vein kind of pinches down like quite a bit, and even have a post-stenotic dilatation. So some of these observations led to the notion of exploring pressures along the veins. So what's the science behind it? Why is it that the pressure rises in the vein? So it was found some time ago that the CSF drains into veins through tiny little arachnoid granulations. And then appears to there needs to be a pressure gradient of about 2 to 3 millimeter mercury. So the CSF pressure needs to be slightly higher to drain into these arachnoid granulations. So and they're sitting inside the vein, as you can see here in the middle of my picture, this really round defect is one of these arachnoid granulations. So when the venous pressure rises, because there's a narrowing and the blood cannot get out of the brain, then the ICP also rises, probably as a secondary effect. Although that process is not fully understood. And so in idiopathic intracranial hypertension, we have seen that bilateral outflow obstructions can actually increase the pressures intravenous, but also inside the brain. And although it is still not known what exactly causes the disease of idiopathic intracranial hypertension, we know that the veins appear to play a role. We see various formations of veins, of these transverse veins. Some of them have more longer and more narrowed compression, which has been referred to extrinsic compressions, seemingly from a higher pressure from the brain itself. But we also sometimes see intrinsic compressions or pressure buildup through like something like enlarged arachnoid granulations and other maybe like prior thrombosis or other areas like you can see on the right side where the transverse sinus is quite heterogeneous and very irregular. And that in itself can also lead to pressure buildup. So what actually needs to happen before a venous manometry procedure? Usually you have to have some non-invasive picture that shows you that there is perhaps an abnormal vein and that is detected. So on the picture on the left, you can see the transverse sinus. It's best evaluated in a sort of coronal view after contrast, and it should be a nice triangle. It's important to realize that it is not a round cylinder, which is why it's sometimes not clear whether a narrowing is affecting the pressures or not. So on the left, you see a normal triangular transverse sinus, and that's very symmetric. And in the middle, you see one from an IIH patient, which is very compressed and narrowed. In IIH patient, in reported series, about over 90% can have abnormalities in their transverse sinuses. And but often these abnormalities are not very well reported because they can also be seen in individuals who do not have raised intracranial pressures. So it takes really an expert to evaluate these veins to see whether a narrowing is suspected. And it's also important to rule out any other abnormalities like, a fistula or a blood clot or anything else that can lead to an abnormal narrowed transverse sinus. One of the things that is interesting is the sort of asymmetry that can be seen in those transverse sinuses. So almost all transverse sinuses are slightly asymmetric. They can be quite co-dominant in terms of outflow and size, but a lot of them are in fact asymmetric. And describing that, whether it's done, before or during angiography, leads to a better understanding as to what is going on. So on the very left picture, you see a more right dominant outflow of the transverse sinus. In the middle, it's slightly more right dominant, but there's a narrowing on the left side. And on the very right side, you see co-dominant sinuses with bilateral narrowings, which in IIH patient, we need to have bilateral transverse narrowings. And this is kind of important to realize because one of the most common questions that I get is like, is this IIH? And then I look at the images and people just have an asymmetric sinus. And so one is smaller than the other, but there's really no obvious narrowing. And so in order to really develop higher pressure, in my opinion, either you have an aplastic one side, meaning that there's barely any blood flow going through it, and then narrowing in the other one. But if you have one side that is flowing really well and the other one is aplastic, it's, in my opinion, really hard to develop into high pressures in such a situation. So describing and understanding the laterality of it is an important step in a venography procedure. So the procedure by itself. So various ways of doing a venous manometry have been described. They're done as part of a venography procedure. So the access is through the vein. Typically, we would access through the leg, through the femoral vein. And one can also go through the internal jugular vein, although we like to avoid that because it's one of the major outflow veins on the brain. And so we don't like to have any issues there. But most recently, I almost exclusively now use the basilic vein for access as a venography procedure, which is a vein right above the elbow. It's also used for PICC line access, if you're familiar with that. And it's a fairly safe vein to access under ultrasound guidance. And so when I access the vein, I usually use a 4 French access system, which is just a way of telling how big the access site is going to be. 4 French is somewhat on the smaller side for us who do those procedures. And I use a microcatheter with a fiber optic wire. And that microcatheter is let me see. So the microcatheter gets placed right at the jugular bulb at the skull base, sort of the 4 French catheter. And then from there, I use a microcatheter to go all the way up into the supraoccipital sign, and I kind of align it, the sensor, as if I would do a lumbar puncture all the way in the same line. Now, and here you can see I use an angiography and a vein to demonstrate the vein, so I do not go blindly up there to sort of check where I'm going.
Can I ask a question, Dr. Altschul? So tell me more about the sensor or the wire you're using. So you're measuring pressures. Uh,
Yeah, so that's a fiber optic wire. It has a 15 mm nitinol tip at the end, so you can shape it. And you can put it through a microcatheter and you can access with the wire. Its navigability is not as good as it is with a micro guide wire, but it will
Sure.
get you to the right places. Sometimes I do have to use a micro guide wire. So I would use the micro guide wire, bring it in position, take the guide wire out, and put the fiber optic wire in. Fiber optic wire is borrowed from cardiology. Every cardiac cath lab has it. So if you go to your cardiac cath lab and ask for the opto wire or a fiber optic wire, they will give it to you. It's already in every hospital system. And it gets connected to a box. It measures the pressure in real life, so you don't have to level like you would do if you would do a
Sure.
traditional venous manometry, which is another way of doing it where you just use the micro catheter, which should be bigger than what I'm using here. I use a very small microcatheter, but in a traditional venous manometry that gets leveled in the mid-axillary line, which is sort of aligned with the right heart, you want to have at least, and the data is very scarce here, but you want to have at least a 0.27 microcatheter.
Mhm.
And I think that's mostly because if you have, for example, kinks in the microcatheter, that may affect the pressure reading. So having a good sort of size microcatheter to have good flow will give you a better sort of pressure transmission, and you make sure that you don't have bubbles in there and stuff like that because that can affect it. But the Play-Doh wire actually that I'm using here is one that doesn't kink.
Mhm.
And so I like it because it doesn't overlyse either. So if I had to take a pressure measure with traditional venous manometry, I could. but I usually don't have any trouble getting where I need to go with the opto wire, and so this is how I do it.
Understood.
And I used to do it the other way before. So 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 you need to take various assessments during venous manometry, and there is no standardization, but this is how most of us who do this. So we start at the superior sagittal sinus, which is the number one over the convexity. And here, generally, it should be reading less than 80 millimeter mercury to correlate with an opening LP pressure of less than 250 millimeters, or that would be 25 centimeters of water. It's important to realize that what we measure with a venous manometry or a fiber optic wire is millimeter mercury. What we measure through a lumbar puncture is centimeter of water or centimeter CSF. So it doesn't fully correlate, and you have to multiply times 1.36 the millimeter mercury to get to the centimeter of water, which is I have to remind everyone to do that. And so we go, once we are in position, it's very easy because you can just pull back the wire and get the measurements. And I always measure the dominant vein, unless there's an issue that I'm looking for in a non-dominant vein. I try to only access one internal jugular vein and try to go over across the midline to the other side. Now, that's not always possible, and that's where this venogram comes in to assess how the brain drains. And sometimes it is very well necessary to go through the other side, but it depends on sort of what my interest is. Kyle Fargan has looked at correlating the superior sinus pressures with the opening pressure. And he has found that actually the torcular pressure, which is number 3, correlates best with the opening pressure from the lumbar puncture. I'm not sure how reliable this is, because it's not always done at the same time. But it's you can see here the graph between opening pressure of a lumbar puncture and superior sagittal pressures. There is a sort of a correlation, but there's still a wide variability. Also, in the assessment of venous manometry, we also look at the pressure gradients across stenosis. So not only do we measure all the pressure measurements, but we also try to assess where there are transstenotic pressure gradients. And so we look how big is the gradient before, and we call it upstream and downstream of a stenosis. And we look for, currently in a transverse sinus, we look for a difference that should read more or equal than 8 millimeter mercury. That is a number that is somewhat arbitrarily assigned. However, it is clinically pragmatic, and it is sort of a number that we look for. Why do we go for the length of doing this? Well, because sometimes we can't be sure that a stenosis is really hemodynamically significant. It's really hard to evaluate them sometimes. There is also inflow from other flows, from other veins. It can look like there's a stenosis. But when you actually measure the gradient, it's really not there. And then it begs the question, is this significant? There was another study that looked at what point of a degree stenosis do the pressure gradients go up, and it seems to be fairly low, like around 30 to 35%, where we start seeing already significant pressure gradients. So currently, if I see a 30 or 35 stenosis on an MRV, I'm thinking, oh, could this be hemodynamically significant? Versus before, I would want to be like more than 70 or 80%, for me to think, oh, this could be clinically significant.
I'm just trying to jump in and ask a question from the chat. So someone asked what pressure gradient is considered significant. I think you definitely addressed that. And then it says, does that threshold vary depending on a patient's symptoms or lumbar puncture results?
Yeah, so I will get to that. I have a graph, and so I will show you that. But yeah, there's a lot of factors that go into whether you would consider that significant. But I can tell you that there were multiple studies that showed that the higher the gradient, the better the clinical response.
Mhm.
And so, and I want to say that my super responders, so this is not published, but there are some super responders, and those super responders, their gradients are really high.
Mhm.
So gradients seem to matter. Um, so,
And are their opening pressures high on LP?
yes.
Yeah.
So why would you even consider doing a venous manometry, right? So what are the indications? And so for me, the indications are that someone has a diagnosis of IIH, or they have a pulsatile tinnitus that is very disabling to them, or they have papilledema. So these three things would prompt me to look at their transverse sinuses and consider a venous manometry. And the reason is that, as I said before, you want to distinguish an incidental narrowing or something that's maybe not significant from something that could be significant. And so we look at absolute venous pressures, but which were the ones in the suprachoroidal sinus, but we also look at pressure gradients. And um, I use this little interprocedural form that I have adopted from UCSF. This is published in one of the papers by Matt Amens, if you're interested, if you're doing these procedures. And so these are sort of the metrics that we record in order to be most systematic and not to overlook anything when we do these procedures. And I do recommend for everyone who's doing it to be very systematic with it. Um, so highly recommend that. And now to answer the question, so a transtenotic gradient that is less than 4 millimeter, I usually consider normal, and I wouldn't recommend any intervention. One that is 4 to 8 is really borderline, and it has to be considered in like the context and the symptoms of the patients. And one that's more than or equal than 8 is probably pathologic, although I hate to use that word, is just mostly that the response rate is going to be better for that patient as it's going to fix a higher gradient. Whether it's really pathologic or not, I think, remains to be a little bit determined because any kind of pressure measurement is also just a snapshot in time. But multiple studies, as I listed before, do mention that number, and I would second that from my experience. And so here you see
Real quick is sorry to keep jumping in. Does that gradient, is that for both IH and pulsatile tinnitus, or do you think about those differently?
Yes, I think about them a little bit different. So for IIH, you want to have a high gradient and also a high transcranial gradient to have a super responder. So you
Yeah.
want to have ideally a low number in internal jugular vein or right heart, and a high number in the brain. That is, I think, something also why I do the venous manometry, because seeing these transcranial gradients will help me determine whether a stent would be something that the patient would best benefit from.
Mhm.
For a pulsatile tinnitus, I think there it is the gradient is important, but there are other things. So for example, if someone has a dehiscence or a diverticulum, along with a gradient that's not so high, I would still consider stenting that because it's actually not the increased noise production that gives the noise, but it's the fact that the bony envelope is maybe dehiscent or thinner, allowing them to have an ability to pick up the noise. So it kind of depends a little bit on the situation. Now, this was a IIH patient that I'm showing here was a 30 in the torcular and a 14 in the sigmoid sinus. This is sort of how I look at the transstenotic gradient before and after. And so the pressure differential was 16. And then after the stent went in, it went down to 14 and 12. And there was a change, now a more normal transstenotic gradient of 2. And that's the silver stent used here. I always measure pressures. I am going around the country, and a lot of people say, oh, it's not necessary to measure pressures. I don't necessarily agree with it. I think there's a lot of things we don't understand, including these like sort of different types. So everyone who has done a lot of venous manometry and who does that all the way down to the right heart will start to see different patterns. And there are really different kinds of sort of intracranial venous hypertension, which is intracranial raised pressures in the vein intracranially. And Kyle Fargan tried to sort of distinguish them. There may be even more types. And I find that very helpful because, for example, I know that the patient on the left who has a high intracranial pressure and a low venous pressure with a stenosis will have the best response to a stent, versus the one on the right, where the right has also higher abdominal pressures and has a stenosis. Those can also benefit from like losing weight and stuff like that. So there are really different ways of looking at it, and I feel like we need to have a better understanding of the different forms.
Can I jump in and ask two questions there?
Mm-hmm.
Who are the people you're saying there's people who don't believe in measuring pressures? Is that like neurointerventionalists who just would treat off of a stenosis without measuring the gradient?
Um, yes, yeah, so they believe that the key thing is the papillary edema or the pulsatile tinnitus,
Mhm.
and the gradient is a secondary metric.
Sure.
Um, Also because the gradient was arbitrarily selected. So we
Sure.
really do not know where it becomes significant. And then the other thing is, should you measure it after your stent? And so I always measure it after I stent. But there are a lot of people who say that they don't measure it. And I think part of it is also because a lot of people do stenting under general anesthesia, versus
Sure.
a venous manometry is best done in an awake situation. So we really don't have good guidance as to how to interpret when now the venous gradients are different because the patient is now asleep. You know what I mean?
Yeah. Understood. Yeah. Yeah.
Yeah.
Interesting. And then
So,
go ahead.
yeah.
And the second thing I was going to say, those four patients you listed, the three on the right are also trouble for VP shunting. I mean, so like, the shunt has to end somewhere. So if they have high intrathoracic or intra-abdominal pressures, those patients are a nightmare for neurosurgeons placing a shunt. You're going to get a lot of shunt failures because you have to have a gradient there as well from the head to the abdomen or to the head to the chest.
Yeah. Yeah, it's very interesting. So, now more recently, I have started to pay attention to the jugular veins because it's a very a lot now, actually. People come with an increased intracranial pressure, but they don't have a transverse stenosis. And so the question is, why is the pressure high? And I've started to pay attention to the jugular veins. And so this is something that, in very recent times was not part of my sort of systematic evaluation, but it's a fact that when you are in a supine position, the internal jugular vein should be widely open. And when you are in an upright position, they actually collapse and the vertebral network takes over. And so when we, under normal situations, when a patient has a test that's in a supine position, they will have a vein, how this vein looks like it's widely open, at least at the C1 level here, as it comes out of the skull base. But when you start really paying attention, all of a sudden you start seeing veins that kind of look like this. They're quite pinched right at the C1 transverse process. And this upfront, that bone is the styloid process. And you kind of start to wonder, why is that, particularly since they should open up as they are lying down. And I do not bother with that unless I see that the pressures are high. So some of you may have heard of Eagle syndrome, which is a bone, the styloid bone, that can compress various structures when it becomes elongated and maybe calcified, and it can start to compress various nerves in that area. Evidently, only 4% of the population have an elongated styloid. But some of these people do report symptoms like pain in the face or neck or throat, particularly when chewing or turning their head. They're feeling that there's something in their throat, difficulty swallowing. Sometimes they're ringing, and it's not necessarily prostatitis, headaches or dizziness. And now this is a very rare thing. However, this situation can sometimes also cause what we call vascular eagle syndrome, which means that with certain head rotations, flexions, extensions, the internal jugular vein at the C1 level can be compressed. And in fact, the styloid can also cause carotid dissection. And when you look at the latest guidelines, one should look at the styloid if it was in close proximity of a carotid dissection. Often in the waiver image, currently people in their supine orthogonal view, we don't see these things. But for those of us who do dynamic testing, once you start rotating the head and you check the pressures, you can see incredible pressure spikes. I do not know the significance of it. I think this could be perhaps normal. I don't know. But it is a fact that the pressure in some people will go up with very minor head movements. And these tests are very difficult to do because they should be done awake, and so the patient has to participate. And that's also why I use the fiber optic wire, because it's sort of easier with patient movement to get more accurate readings. And so this is, for me, another reason to do venous manometry, to see whether there is any sort of pressure gradient that is more located in the neck rather than in the head. I know that some people look even further down, for the sternocleidomastoid mastoid, and there are data on that as to how head rotations affect pressure measurements. And I think we're going to hear a lot more about it in the future. Again, I do not consider it significant until I see actual high pressures in the head in an orthogonal view without head rotation. Now, in terms of the procedure, is generally considered safe. The pure venographic complications are very low, 0.14% reported. If a cerebral angiography is adding a permanent neurologic deficit as a part of this procedure has been reported around 0.5%. Though that's a permanent neurologic deficit. There could be other smaller issues like access site complication and stuff. They're usually something that we can deal with. It does require a highly specialized room to do these procedures, and sedation is important, but it's also important to consider the right sedation for the right patient so as to not to influence the pressure measurements. And so after the procedure, if it's done for the arm, the recovery period is incredibly short. The patient, goes home within 2 hours after the procedures. They have some restrictions, 24 to 48 hours, mostly for the arterial access side and the wrist, and the results are reviewed with the entire care team. You do want to avoid general anesthesia as it can increase the pressures in the sigmoid and the jugular vein, thereby changing the gradients. And if you do have to do it in certain people, it's unavoidable to keep the map and the CO2 stable. And what can affect pressure readings? A lot of different things, such as body position, as we discussed, hydration. So if they get a lot of fluids, the CVP will go up. Caffeine before the procedure, medications, we hold Diamox, ideally 5 days before, though there are some pharmacological data that maybe 2 or 3 days is okay in people who were really dependent on the Diamox. Anxiety can increase. Propofol can decrease pressure readings, gases increase, vasodilation can increase pressure readings. A recent lumbar puncture can temporarily change pressures. We avoid using venous manometry within 2 weeks of a lumbar puncture. So it's very important. I guess what I'm trying to say here is that these pressure readings are really just a snapshot, and they're not, written in stone. But I feel like for every patient we measure, we learn a little bit more about how the brain balances pressure, flow, and function. And I think there ought to be more research done in that area, and I hope to be part of it. So just to summarize, venous manometry directly measures brain vein pressures. It's key to diagnosing and treating IIH with venous sort of procedures. It works together with lumbar puncture to understand the whole picture. And stenting can relieve symptoms when pressure gradients are high. So thank you for your attention. And if there's any questions, I'm here to answer those.
Okay. So one question, it's going to let you have a stab at this. Patient or someone asks, what if you have already had 2 ICP monitors that both showed high pressure?
You have high
Any other
pressure.
Yeah, it's kind of vague, but
That means that they have high pressures. I mean,
yeah.
you're probably the expert in ICP monitors. How trustworthy are ICP monitors, Brian?
Yeah, I mean, most of my experience with ICP monitors is with ventriculostomies, mostly because, as you mentioned, we put them in the trauma setting, and we needed them to be both diagnostic and therapeutic. So I'm sure there's a lot of literature about those intraparenchymal monitors that you talked about earlier, but outside the trauma setting, in pediatrics, we sometimes put them in pediatric patients for low ICP issues, but I'm assuming that they have some sort of evidence behind them, but how trustworthy they are, I'm not sure. So again, without more clinical information, I think it's just tough to know that you should probably follow up with a neurosurgeon or a neurointerventionalist who, those are usually 2 specialties that sort of deal with this. I don't know how you feel about that.
So actually, Bobby Stark did a study where they had put into IIH patients. So these were not, these were not normal physiology. So these are
Mm-hmm.
people who had already been diagnosed with IIH. They put ICP monitors, and then they stented those patients, and they could correlate the decrease in venous pressures after the stent with also a contemporary decrease of the interparenchymal pressures from the ICP monitor. There were, I think, only 10 patients, and this study was reproduced by one other study, I think, but it was also only 10 patients. So we have very limited data available in terms of how well it correlates, but sort of the general trend was there in both measurements.
Understood. Next question is, are there clinical scenarios where venous manometry shows an apparent significant gradient pressure with no objective anatomic pathology?
Um, I don't think so. So if well, I should rephrase this. I don't usually measure pressures if there is no pathology. So for me, the indication to measure is to measure because there is already some pathology. So I don't measure normal people, right? So I don't know how it would look like in this people, but there's either an absolute increase of pressure, so meaning someone has an increased pressure on the suprachiasmatic sinus because they have a diagnosis of raised pressures,
Right.
or they have a transsternal gradient that not necessarily needs to be at the transverse sinus. So we see, gradients also in the suprachiasmatic sinus. Most recently, I was introduced to stenosis in the straight sinus and pressure
Hmm.
gradients there. And there are already people stenting the straight sinus. And then, as I said, also in the neck. So so I can't really answer because I don't do normal people. So I don't know.
Yeah, understood. I think that's it for the questions in the chat. I had one question for you. You know, I guess how I think about it, or maybe correct me if I'm wrong, but for those of us that do this, manometry seems to be becoming more standard for IIH patients. But let's say you get someone that you have to go see in clinic. Um, they have pulsatile tinnitus. You see some maybe stenosis on their, on their non-invasive imaging. Are you going to do manometry, but are you also doing an arteriogram on these patients, or are they getting signed up for simultaneous angiography plus manometry, or are you just going straight to manometry?
Um, so I do angiography and venous manometry together
Mm,
just because I want to understand the overall outflow patterns
sure.
of the venous system. And, I don't know, you probably have been doing this for a long time. I've been doing this for a long time. I always stare at the arteries and I have really ignored the veins. But once you make a switch and you start staring at the veins,
Yeah.
you see things that, you should appreciate when you are doing this kind of work. And so I feel like if I don't look at this, I leaving out an opportunity to understand this better. Now, does this mean that you have to do it that way? No. I just feel like it's safer for me because I use it as a roadmap to go up and things like that. I think most people would say that, and this is, quoting people like out of NYU and stuff, that an arteriogram is not necessary in a workup of a pulsatile tinnitus patient. That means that all non-invasive testing will give you an answer as to what is going on with that patient. So you don't need an arteriogram to necessarily figure out why the patient has pulsatile tinnitus. But if you want to treat pulsatile tinnitus, I think having a venous manometry, understanding pressure gradients, understanding outflow patterns, dominance, and et cetera, is helpful.
Yeah, I mean, maybe that's particular to NYU, but I feel like a lot of places, sometimes I don't know I'm curious to get your thoughts on this. One thing I want to make sure is they don't have a fistula. And, some of my imaging that I get done, or some of the imaging that people bring to me from various outpatient centers, I don't think it meets the criteria of like sufficiently ruling out, um, an AV fistula. So I think it's pulsatile tinnitus. It's almost like IH. I think it's a tough disease. You get something from ENTs, from neurologists. These patients have been bounced around. They have nowhere to go. And now that this seems to be becoming more and more of an option, when I see someone like that, I'm signing them up for an angio to look for a fistula or make sure nothing else is going on. it sounds like I should probably also be signing them up for manometry as well. Is that
If
is that how
you
you think
could,
about it?
yes, if you're considering a stenting as an option as from a non-invasive perspective, then
Yeah.
yes, because, and I tell you why I do it that way. The truth is that I like to do venous manometry awake and I like to do stenting asleep. And
Hmm.
I and because I feel like putting them asleep off the get-go under general anesthesia, how I do my stents,
Hmm.
is may give you the wrong impression as to what is going on. And so that's why, if anything, I would either convert if I would do it at the same time as stenting, or I would bring them back on two different occasions. Now, everyone is different, and there are people who cannot tolerate being awake. It's there are people who cannot lie flat.
Hmm.
So there are a lot of different scenarios that have to be considered. But mostly I, once you do I think it's unforgivable to have a complication from a stent if the patient moves or something like that. And once you
Of
see,
course.
but you see, because there is maybe 10% of people, they are very sensitive on the dura, and even microcatheter makes them very sensitive. And you don't know
Sure.
that until you're there. And that's also for me, I know immediately when I do the venous manometry who is sensitive and who isn't. So
Right.
that's also an information that I can gather from it. But yeah, we don't, not everyone has NYU type imaging. I agree with that. And second of all, we all have that case where they had all images and then they have like a small spinal fistula or something.
Yeah.
We all have that case. And you do not want to miss that when you go and do a stent, because it's quite an invasive procedure for something like pulsatile tinnitus, in my opinion. So you want
Right.
to make this, you want to do this the right way.
Understood. I think that's all the questions in the chat. There's a question about complications. What is the major complication of the procedure? I think you went over that in detail about the complication rate of angiography and venography. Um,
Yeah, it's quite small. It's very well tolerated. It has a disadvantage that you can't drain fluid. The lumbar puncture is better that way because you can send a sample and you can drain someone down, kind of making an assessment how they would be with a lower pressure. I have actually for some time given people mannitol during the procedure to sort of have the same effect to see.
right.
Um, and I think it's helpful, but it's a bit, yeah, it's a bit uh, more, there's a lot of urination involved in that.
Sure. Of
So it's
course.
not an in and out procedure and it needs a different level of care. But I think it's a fairly safe procedure, venography.
Awesome. I see Edith back. I think we put everything in the chat with how to find you, your email, your website. You got a
Yeah.
book?
Yes, I have a book. And so it's quite detailed book about everything I've said and then some. So if anyone is interested, I'm happy to share it. I have it in PDF format.
Great.
Thank you very, very much. And we will be publishing an article to recap and connect you and to anyone who would like a copy of your book. Also, we will place this whole video on our YouTube channel for anyone to rewatch or anyone who missed it. But we thank you very much for your expertise in this topic and for treating those with pulsatile tinnitus and IIH. We're very grateful to have you in our community. And if anyone would like to see Dr. Altschul as a patient, we do have a patient provider page on our website. You can find any information about her on our website as well. And thank you very much for your time. We hope to have you again in, 6 months or a year again.
Thank you. Thanks, everybody.